Osteoporosis, or bone loss, is a common health problem that many people face as they get older. In this video, I will cover 8 different treatment options for osteoporosis, ranked step by step from the least effective to the most effective. 8. Alternative and complementary approaches. Alternative and complementary therapies do not directly increase bone density, but they can play a supportive role in managing pain, reducing fall risk, and improving overall quality of life alongside primary medical treatments. 1. Yoga and Tai Chi effect. Improve muscle strength, flexibility, and balance. They help prevent fractures by reducing the risk of falls. Scientific evidence. Tai Chi has been shown to reduce fall risk by 47% in older adults. Regular yoga practice improves spinal alignment and reduces back pain. Clinical significance. While they do not directly affect bone density, these practices are highly valuable in indirectly preventing fall-related fractures. 2. Acupuncture effect. Helps manage pain, especially in the lower back and spine due to osteoporosis, may enhance blood circulation and promote overall relaxation. Scientific evidence. Acupuncture has shown statistically significant reductions in back pain related to osteoporosis. Clinical significance. It has limited effect on bone density, but serves as a useful complementary method for pain control. 3. Herbal supplements and natural products effect. Phytoestrogens, such as soy isoflavones, may reduce bone loss in postmenopausal women. Omega-3 sources, like flaxseed and fish oil, may reduce inflammation and support bone health. Scientific evidence. Soy isoflavones have been shown to slow bone loss in postmenopausal women. Omega-3 fatty acids may have positive effects on bone remodeling, especially in animal studies. Clinical significance. Effects are mild and variable. These should only be used under medical supervision and as a supplement to standard treatments. 4th, massage therapy and reflexology. Effect. Promotes muscle relaxation, reduces pain, and lowers stress. Can improve sleep quality and overall well-being. Scientific evidence. Regular massage therapy significantly reduced pain and anxiety scores in individuals with osteoporosis. Clinical significance. It does not directly impact bone health, but can greatly enhance patients' quality of life. 5. Functional medicine approach. Effect. Addresses multiple factors such as gut health, vitamin and mineral absorption, inflammation, and hormonal balance. May support bone health indirectly by enhancing absorption of vitamin D, calcium, and vitamin K2. Scientific evidence. Studies on the gut-bone axis have shown that gut health can influence bone metabolism. Clinical significance. A relatively new but promising approach, especially in individuals with absorption issues. Important reminder. These methods should never be used without medical supervision. Their scientific backing may be limited, and they can sometimes interact with conventional treatments. The best outcomes are achieved when these approaches are intelligently combined with evidence-based medical therapies. 7. Lifestyle modifications and exercise. Lifestyle changes and regular exercise are essential components of osteoporosis treatment. While they may not increase bone density as much as medications, they play a strong preventive role by slowing bone loss, reducing fall risk, and improving overall health. 1. Weight-bearing exercises. Examples: walking, dancing, climbing stairs, light jogging. Effect: stimulate bone formation by applying mechanical stress to bone tissue. Help maintain bone density, especially in the hips and spine. Scientific evidence. Postmenopausal women who engaged in regular walking showed a 1.5% increase in bone mineral density, BMD. 2. Resistance training examples: lightweight lifting, resistance band exercises, bodyweight exercises. Effect: increases muscle mass, placing greater stress on the skeletal system, strengthens muscles around the spine and hips, reducing the risk of falls and fractures. Scientific evidence. Participants who performed resistance training twice a week for 12 months showed a significant increase in spinal BMD. 3. Balance and coordination. Exercises examples: Tai Chi, balance board exercises, yoga. Effect: enhance balance reflexes, which tend to decline with age, play a major role in preventing fall-related fractures. Scientific evidence. Older adults who performed balance exercises reported a 24% reduction in fall incidence. 4th, smoking cessation effect. Smoking suppresses osteoblast, bone-forming cell activity, and increases bone resorption. Scientific evidence. Bone density in smokers is 5 to 10% lower compared to non-smokers. 5. Reducing alcohol consumption effect. High alcohol intake impairs calcium absorption and vitamin D metabolism. Scientific evidence. Individuals who consume more than 7 alcoholic drinks per week have a 30% higher risk of hip fractures. 6. Vitamin D and sunlight exposure. Effect: sunlight stimulates the body's production of vitamin D. Vitamin D promotes calcium absorption in the intestines and its integration into bone tissue. Scientific evidence. Individuals with low vitamin D levels have twice the risk of fractures. 7. Fall prevention and home safety modifications. Effect: preventing falls is the most direct way to reduce fracture risk in people with osteoporosis. Suggestions include securing rugs, using non-slip mats in the bathroom, installing night lights, and adding grab bars in key areas. Summary: lifestyle modifications: reduce fracture risk, slow bone loss, enhance the effectiveness of medications. However, these strategies alone do not cure osteoporosis. The best outcomes are achieved through a combination of pharmacological treatment, exercise, proper nutrition, and lifestyle adjustments. 6. Calcium and vitamin D supplementation. Calcium and vitamin D are essential nutrients for bone health in both the prevention and treatment of osteoporosis. Obtaining these nutrients through diet and supplementing them when necessary is of vital importance. 1. The role of calcium effect. 99% of the calcium in the body is stored in the bones and teeth. It acts as a building block in the processes of bone formation and remodeling. Daily requirements. Adults, 1,000 to 1,200 milligrams per day. Postmenopausal women and older adults, 1,200 to 1,500 milligrams per day. Scientific evidence. Older women who consumed 1,200 milligrams of calcium daily showed a 12% reduction in hip fracture risk. Dietary sources: milk, yogurt, cheese, almonds, sesame seeds, broccoli, sardines. 2. The role of vitamin D effect facilitates the absorption of calcium from the intestines. Without adequate vitamin D, calcium intake alone is ineffective for bone health. Daily requirements. Typically 800 to 1,000 international units per day. Some sources recommend up to 2,000 international units per day for older adults. Scientific evidence. Individuals taking 800 IU of vitamin D and 1,200 milligrams of calcium had a 43% lower risk of fractures. Those with vitamin D deficiency had twice the risk of falling. Sources: sunlight, 10 to 20 minutes per day, salmon, mackerel, egg yolk, vitamin D supplements. Third combined supplement use. Effect: calcium alone is insufficient without vitamin D. Therefore, these two supplements are often prescribed together. Clinical recommendation: for optimal absorption, calcium should be taken in divided doses of 500 to 600 milligrams throughout the day. When combined with vitamin D, bone density is better preserved. Scientific evidence: calcium plus vitamin D supplementation reduces total fracture risk in older adults by 15 to 25%. 4. Be cautious of excess. Intake risks: consuming more than 2,500 milligrams of calcium per day may increase the risk of kidney stones. High-dose vitamin D intake, above 4,000 international units per day over long periods, can cause hypercalcemia. Recommendations: vitamin D levels, 25 OD, should be measured before starting supplementation. Dosage should be adjusted based on age, absorption capacity, and existing bone loss. Important note: treating osteoporosis without calcium and vitamin D is not an option. However, these supplements alone are not sufficient. They should be combined with exercise, proper nutrition, and medications if necessary. 5. Hormone replacement therapy, HRT. Hormone replacement therapy, HRT, is an effective method used to prevent bone loss caused by decreased estrogen levels, especially in postmenopausal women. However, due to its potential risks, careful patient selection is critical. 1. How does it work? After menopause, estrogen levels drop, which increases bone resorption. HRT restores estrogen levels, suppresses osteoclast activity, bone breakdown, and helps preserve bone mineral density, BMD. It is particularly effective in reducing the risk of spinal and hip fractures. 2. Who is it suitable for? Women aged 50 to 60, those who experience early menopause, individuals at high risk for osteoporosis who have not responded to other treatments, women with significant menopausal symptoms, hot flashes, insomnia, mood changes. 3. Scientific evidence on effectiveness. HRT reduces the risk of hip fractures by 34% and spinal fractures by 33%. It is highly effective in improving bone density in postmenopausal women. Fracture risk significantly decreases during the course of treatment. 4. Which hormones are used? Estrogen suppresses bone breakdown, the main active ingredient. Progesterone lowers the risk of endometrial cancer and is essential for women with an intact uterus. 5. Risks and considerations. While HRT is effective, it also carries important risks and should be used with individualized risk assessment. Breast cancer. Long-term use may increase the risk. Blood clots. Higher risk of deep vein thrombosis and pulmonary embolism. Stroke. Caution is advised especially in women over 60. According to WHI, Women's Health Initiative, data. Using HRT for more than 5 years may increase breast cancer risk by 26%. 6th clinical recommendations. HRT is not the first-line treatment for osteoporosis. However, in women who experience menopausal symptoms and do not have other major risk factors, short-term use, 3 to 5 years, can be appropriate for both symptom relief and bone health. Before starting HRT, breast examination, evaluation of family history, cardiovascular risk analysis, these are all essential. Important note: HRT is an effective option for postmenopausal osteoporosis, but is not suitable for everyone. Decisions should be made under medical supervision based on a personalized risk-benefit analysis. Fourth, oral bisphosphonates. Oral bisphosphonates are the most commonly used class of medications in the treatment of osteoporosis. They are particularly prescribed to postmenopausal women and older men to slow bone loss and reduce fracture risk. They are generally considered first-line treatment. 1. How do they work? Bisphosphonates inhibit the activity of osteoclasts, the cells responsible for bone resorption. This reduces bone breakdown and helps maintain or increase bone mineral density, BMD. They are especially effective in preventing fractures in the spine, hip, and wrist. 2. Commonly used oral bisphosphonates alendronate. Once weekly risdronate, once weekly or monthly ibendronate, once monthly. Note, daily formulations are rarely used. Weekly or monthly dosing is preferred for better patient compliance. 3. Evidence of effectiveness. Women taking alendronate saw a 47% reduction in vertebral fracture risk and a 51% reduction in hip fracture risk. Risdronate reduced the risk of new vertebral fractures by 41% over a 2-year period. 4. Usage instructions. Very important. Correct usage is critical to both the effectiveness and safety of bisphosphonates. Improper administration may lead to serious side effects. Recommendations for proper use. Take the medication on an empty stomach, first thing in the morning, with a full glass of plain water. Do not lie down, eat, or drink anything else for at least 30 minutes afterward. Only plain water should be used. Avoid mineral water, juice, or other beverages. Side effects and warnings. Gastrointestinal issues. Heartburn, esophageal irritation, esophagitis, jaw osteonecrosis. Rare, especially after dental extractions. Atypical femoral fractures. Very rare. May occur with long-term use, greater than 5 years. To minimize these risks, a drug holiday, temporary discontinuation, may be recommended after 5 years of use. This decision should always be made by a physician. 6. Advantages. Strongly supported by scientific evidence, clearly reduces the risk of fractures. Generally well tolerated when used correctly. Affordable and widely accessible treatment option. Important. Note, oral bisphosphonates are among the first choice medications for treating osteoporosis. However, treatment success depends on correct usage, proper patient selection, and ongoing monitoring. Third, intravenous bisphosphonates, zoledronic acid. Intravenous, IV, bisphosphonates are an effective alternative for patients who cannot tolerate oral medications or who experience gastrointestinal side effects. The most commonly used IV formulation is zoledronic acid. 1. How does it work? Zoledronic acid suppresses osteoclast activity, thereby reducing bone resorption. As a result, bone mineral density, BMD, increases and fracture risk decreases. It shares the same mechanism of action as oral bisphosphonates, but is more potent and has a longer duration of effect. Second method of administration dose, 5 milligrams of zoledronic acid frequency, once yearly via intravenous infusion. Duration? Administered over 15 minutes. This once-a-year dosing provides a major advantage for patient compliance, especially for those who have difficulty taking oral medications. Evidence of effectiveness. When administered once a year over a 3-year period, zoledronic acid has been shown to reduce hip fracture risk by 41%, reduce vertebral fracture risk by 70%, reduce overall fracture risk by 25%. Additional benefit: after 3 years of use, BMD increased by 6 to 9%. Fourth, advantages: excellent patient adherence, does not cause stomach upset or esophageal irritation, significantly reduces both hip and spine fractures, increases bone density, starting within the first year 5. Side effects and risks: acute phase reactions, fever, muscle pain, and fatigue within 1 to 3 days of infusion, occurs in 20 to 30% of patients. Jaw osteonecrosis, rare, but can occur especially after dental procedures. Kidney dysfunction, use cautiously in patients with elevated creatinine levels. Atypical femoral fractures, very rare with long-term use. Note: kidney function, creatinine levels, must be assessed before each infusion. Drinking plenty of water and taking acetaminophen on the day of the infusion can help reduce flu-like symptoms. 6. Who should consider IV bisphosphonates? Patients who cannot tolerate oral bisphosphonates, individuals with poor adherence to daily or weekly pills, patients with sensitive gastrointestinal systems, those with advanced osteoporosis who require fast and effective treatment. Important. Note: zoledronic acid is a highly effective and practical option for osteoporosis patients with high fracture risk or intolerance to oral therapy. However, renal function and dental health must be evaluated before starting treatment. 2. Denosumab, RANKL inhibitor. Denosumab is a biological medication that has become increasingly popular in recent years for the treatment of osteoporosis. It works by targeting a molecule called RANKE, receptor activator of nuclear factor kappa B ligand, which plays a key role in bone resorption. 1. Mechanism of action. RANKL is essential for the formation, activation, and survival of osteoclasts, bone-resorbing cells. Denosumab binds to RANKL and inhibits its activity, thereby preventing osteoclast-mediated bone breakdown. The result is reduced bone resorption and increased bone mineral density, BMD. Second administration dose, 60 milligrams. Frequency, once every 6 months via subcutaneous injection. Can be administered easily at home or in a clinical setting. 3. Clinical evidence of effectiveness. In postmenopausal women treated with denosumab for 3 years, vertebral fracture risk was reduced by 68%. Hip fracture risk decreased by 40%. Overall fracture risk dropped by 20%. Long-term data. Continued use over 10 years has shown sustained increases in BMD. Comparative data. Denosumab has been found to increase bone density more rapidly and effectively than oral bisphosphonates. 4. Advantages. Long-acting, convenient dosing every 6 months. High efficacy, strong fracture protection. No gastrointestinal side effects. Does not cause stomach or esophageal issues. Kidney-friendly. Preferred in patients with impaired renal function 5. Side effects and precautions. Increased infection risk. Slightly higher incidence of upper respiratory and urinary tract infections. Hypocalcemia, especially in patients with kidney disease. Calcium levels must be monitored. Jaw osteonecrosis, rare. Risk increases after dental procedures. Rebound bone loss. Rapid loss of BMD can occur if the medication is stopped suddenly. Follow-up planning is essential. 6. Who should consider denosumab? Patients who cannot tolerate or do not respond to oral bisphosphonates. Individuals with impaired kidney function, low creatinine clearance. Patients with high fracture risk who can be regularly monitored. Important note. Denosumab is a modern and highly effective anti-resorptive agent. However, Due to the risk of rebound bone loss after discontinuation, treatment must always be carefully planned and managed under medical supervision. 1. Anabolic treatments, bone-building agents. The most effective anabolic treatments actively stimulate bone formation rather than just preventing bone loss. They are considered the most effective therapies for osteoporosis and are especially used in patients at high risk for fractures. 1. How do they work? They stimulate osteoblasts, the cells responsible for bone formation. By increasing new bone tissue synthesis, they strengthen the existing bone structure. They rapidly and significantly increase bone mass. 2. Most common anabolic drugs, teriparatide, PTH 1-34, daily subcutaneous injection, abaloparatide, PTHRP analog, daily subcutaneous injection, romosozumab, sclerostin inhibitor, monthly subcutaneous injection 3. Evidence of effectiveness. After 18 months of treatment, vertebral fracture risk decreased by 65%, and non-hip fracture risk decreased by 53%. Significant increases in bone mineral density (BMD) were observed. At 12 months, vertebral fracture risk decreased by 73%, hip fracture risk by 36%. Romosozumab stands out with its dual mechanism, increasing bone formation while reducing bone resorption. 4th, advantages. Rapid increase in bone mass, faster effects compared to other treatments, significant fracture risk reduction, life-saving, especially in high-risk patients. Dual action, romosozumab, increases bone formation and decreases bone resorption. 5 precautions. Treatment duration is limited. Teriparatide and abaloparatide are usually used for a maximum of 18 to 24 months high cost, more expensive than other therapies. Side effects: headache, nausea, muscle cramps, cardiovascular risk. Rare, with romosozumab. Romosozumab should be used cautiously in patients with a history of cardiovascular disease, patients with a high risk of fractures, especially vertebral and hip fractures, those who do not respond to or cannot tolerate other treatments, situations requiring rapid bone formation. Remember, anabolic treatments are the most effective way to strengthen bone health. However, due to cost and treatment duration, they should be used under specialist supervision. To wrap up, while osteoporosis can be a serious condition, the good news is that there are a variety of effective treatments available, from lifestyle changes to advanced medical therapies. The key is early diagnosis, personalized care, and consistent follow-up. Thank you for watching, and don't forget to take care of your bones. They literally hold you up. Age is merely the number of years the world has been enjoying you.